Hello everyone, I'm Dr. Tom Barber. I'm based at the University of Warwick in the UK, and I'll be chairing today's webinar on Polycystic Ovary Syndrome, Novel Perspectives on Pathogenesis and Management. The session will last for 60 minutes, and I will be delivering the first session on pathogenesis of PCOS, particularly focusing on metabolic features of PCOS. And we're very lucky to have my co-presenter, Professor Christian Thaler, who's a renowned professor of reproductive endocrinology and fertility specialist based at the Ludwig Maximilian University Hospital in Munich, in Germany. He'll be delivering the second talk on treatment strategies for PCOS, particularly focusing on fertility treatments. Following the two talks, there'll be a period of around 20 minutes or so where there'll be a Q&A session. And I'd encourage you, please, to write down any questions or queries that you have, and then use the chat function within Zoom to post these, and we'll hopefully be able to address those and discuss answers to those queries in the Q&A session. So let's carry on then with today's topic, and I'm going to share my screen now. So hopefully you can all see my screen now, and this will be the first session, as I said, on metabolic aspects of polycystic ovary syndrome. So the outline of the talk is shown here. I'm firstly going to consider the pathophysiological links between obesity and polycystic ovary syndrome. I'm going to discuss the diagnosis of PCOS, and then consider the metabolic dysfunction in women and girls with PCOS. I'll talk about the importance of weight loss in PCOS as an important treatment strategy, and finally summarize some of the treatment options for PCOS, particularly in relation to weight loss. Here are the take-home messages from the talk. Firstly, that there is a close epidemiological association between obesity and PCOS. Secondly, that the underlying pathogenesis of PCOS is complex, but is driven by weight gain and obesity.
And we don't see a screen, Tom.
Oh, okay. Okay.
Now I see it, but it's not. Yes, perfect. We see it.
Thank you. Thank you. The third take-home message is that PCOS is a diagnosis of exclusion. The fourth message is that metabolic dysfunction in women and girls with PCOS is confined to women with both reproductive and hyperandrogenic features. So they need to have both of the reproductive and hyperandrogenic features of PCOS. And those are the patients particularly who have associated metabolic dysfunction. And finally, successful weight loss remains the best treatment option for PCOS. And so these are the five take-home messages from my talk. So let's look then at the pathophysiological links between obesity and PCOS. And of course, what's shown on this slide is a gross oversimplification of reality, of course. But really the point of showing this is that insulin resistance is central to the pathophysiology of PCOS, and really is the main explanation for why obesity tends to be associated with women with PCOS. And indeed, most women with PCOS are either overweight or obese. Of course, there are some women who are lean who also have PCOS, so it's not the case that you have to have obesity to develop PCOS, but it's clearly very associated. Indeed, there's an independent association of PCOS with insulin resistance, but the point really to show here is that in women who have the genetic predisposition for PCOS, if they gain weight and become obese, then this drives insulin resistance and worsens the entire pathophysiology of the condition. Now, importantly, insulin acts through two main pathways. The PI3 kinase or pathway, or the phosphoinositol 3 kinase pathway, is the pathway which mediates the metabolic features of insulin, and this is the pathway which becomes affected in PCOS and which is worsened by obesity. And this mediates some of the metabolic dysfunction that you can see here on the left-hand side of this slide. Now, importantly, the other main pathway for insulin acting through the MAP kinase, or the mitogen activated protein kinase pathway, this mediates the steroidogenic effects of insulin. And importantly, in PCOS, the MAP kinase pathway remains unaffected. So the compensatory hyperinsulinemia, which comes about because of the insulin resistance, acts through the MAP kinase pathway and mediates some of the reproductive and hyperandrogenic features of this condition, shown on the right-hand side of this slide. Regarding the hyperandrogenic features, insulin acts as a co-gonadotrophin at the level of the ovarian theca cells to drive ovarian production of androgens, which accounts for the hyperandrogenemia and the clinical manifestations of this, including Hirschism, for example, most commonly, but also acne and androgenic alopecia. But in addition to that, insulin also acts as a brake on ovarian follicle development and arrests follicular development at the pre-antral phase, which accounts for the oligoanovulation and consequently the the irregular or absent periods that these women tend to present with. Now, what's not shown on this slide is the effect that insulin also acts at the level of the adrenal gland to drive adrenal androgen production as well. And also what's not shown here is that there's elevated activity of 5-alpha reductase enzyme in women with PCOS as well, which converts testosterone to dihydrotestosterone, which is a more potent androgen. But in addition to that, 5-alpha this also results in the conversion of cortisol to cortisol breakdown products, which in turn drives the hypothalamo-pituitary adrenal axis, which in turn further activates adrenal androgen production. So what you see here on this slide is a distillation really of the main pathophysiological links between obesity and PCOS. As I said, the main point to make really is that obesity is driving insulin resistance, which in turn is driving the 3 cardinal features of PCOS, namely metabolic dysfunction, hyperandrogenic features, and reproductive disturbance. Now, in terms of the diagnosis of PCOS, there are multiple criteria that are out there, but the one that we tend to use and which is most commonly used, I think, clinically, but also with regards to research is what's shown here, the so-called Rotterdam International Consensus for PCOS, which uses the 2 out of the 3 rules. In other words, you need to have at least 2 out of these 3 criteria to diagnose PCOS. And these are, number 1, oligoanovulation, or irregular or absent periods, defined as an intermenstrual interval of at least 35 days. That's the first criterion. The second is biochemical and or clinical features of hyperandrogenism, which is most commonly manifesting as Hirschism or acne or androgenic alopecia. But this could simply be elevated levels of testosterone or androstenedione, for example, or even raised free androgen index, which could be another biochemical marker of hyperandrogenism. And the third criterion is polycystic ovaries, which by definition is at least 12 follicles of between 2 and 9 millimeters in diameter, or an ovarian volume which is greater than 10 centimeter cubed in either ovary. By definition, this is polycystic ovarian morphology. And you need to have 2 out of those 3 criteria to diagnose PCOS. Now, importantly, PCOS is a diagnosis of exclusion. If you look at each of these criteria, each of them is quite non-specific, and many women can manifest with some of these features, even outside of the context of PCOS. And many conditions, multiple conditions, present with features similar to PCOS. So it is very important when we're making a diagnosis of PCOS that we make an effort to exclude these other criteria, because once we make the diagnosis, as with any diagnosis in medicine, it tends to stick and it tends to become replicated and it tends to be accepted as the truth. So I think it's important, to make the effort to really exclude other conditions. Now, what are those conditions? Well, they're shown in this slide. So, for example, we should be checking a serum prolactin. Clearly, elevated levels of prolactin can suppress gonadotrophins and present with oligomenoria in women, and present with some of the features of PCOS. So it's important to exclude hyperprolactinemia. Serum testosterone is also important. Clearly, if this is very elevated, as a general rule of thumb, we should be seeing levels of testosterone less than around 5, but more typically around 2 or 3 nanomoles per liter in women with PCOS. In other words, slightly elevated. But if it's above 5, then that's really the level at which alarm bells should be ringing off, and we should be thinking about possible ovarian tumors, for example, which may be overproducing testosterone and presenting with some of the hyperandrogenic features of PCOS. It's very important to exclude ovarian and adrenal androgenic tumors. 17-hydroxyprogesterone is very important because, of course, this is a good screening test for congenital adrenal hyperplasia. And it's thought that around perhaps 3 to 5% of women who have a diagnosis of PCOS, in fact, have a form of CAH. Okay, so it's very easy to misdiagnose congenital adrenal hyperplasia as PCOS, particularly the milder forms of this condition, which of course can present in adulthood, typically with oligomenoria or hyperandrogenic features. So they present, very similarly to women with PCOS. So we do need to exclude this as well. If the 17-OHP is equivocal, then we can do a dynamic test, short-actin test, to look at stimulated 17-OHP levels, if in doubt, to really exclude CAH. Serum dehydroepiandrosterone sulfate as well, DHES, which of course is an adrenal androgen. Again, it's useful to check that again for adrenal tumors, for example, and androstenedione, which can, more typically ovarian. But again, if this is very elevated, then of course we should be thinking possibly about ovarian tumor, for example. Serum LH and FSH, of course, are usually elevated. In PCOS, there's typically an elevated LH to FSH ratio. But of course, in conditions like hypogonadotrophic amenorrhea, for example, in women who lose weight and in whom leptin levels drop and this switches off the gonadal axis, serum LH and FSH can be quite low or suppressed. And of course, that can present with oligomenoria, features of PCOS. So it's important to look at LH and FSH levels as well. Certain drugs like steroids, phenytoin, and cyclosporine, for example, can manifest with side effects of hirsutism or excessive hair growth. And so, again, it's important to do a comprehensive drug history. And finally, certain endocrine conditions, like, for example, acromegaly and Cushing's syndrome, can also present with disturbances of reproductive function and hyperandrogenic features in women as well. And typically, if they have the clinical features of either acromegaly or Cushing's, we should be following this up with biochemical testing to exclude these conditions in women before making a diagnosis of PCOS. So these are just some of the conditions that we have to exclude in women who present with features which are consistent with PCOS before we make the diagnosis of PCOS. Now, as I mentioned earlier, when thinking about PCOS, it's important to look at subgrouping. And what you can see here on this Venn diagram is an overview, really, of the phenotypic subgroups which come about from the Rotterdam criteria. And of course, if you have 2 out of 3 criteria, this lends itself to 4 separate phenotypic subgroups as shown on this Venn diagram. Now, just to orientate you to this slide, P denotes polycystic ovarian morphology. And as you can see, the large area on the left there denotes the 20% of the female population who have polycystic ovarian morphology. And an important point to make here is that PCO morphology does not equal PCOS. PCO morphology is a very common finding. As I said, in 1 in 5 reproductive age women, PCOS occurs in 5 to 7% of reproductive age women. So in fact, most women with PCO morphology do not in fact have PCOS. Okay, so just remember that PCO morphology, a common finding, and often presents in isolation, but it does not mean, emphatically does not mean, that the woman has PCOS. As you can see, the majority of women with PCOS seem to have all 3 criteria: the PCO morphology, hyperandrogenic features, and oligomenoria. But there are 3 separate subgroups who have 2 out of the 3 criteria, as shown here: PO, PH, and HO. Okay, and all of those would be defined as PCOS based on Rotterdam criteria. Now, a publication shown here, which I myself published back in 2007 in collaboration and with Professor Franks at Imperial College. We looked at the prevalence of metabolic syndrome across the different subgroups, and we found that in fact it was the PHO subgroup, in other words, the group who have all three criteria, who had the elevated prevalence of metabolic syndrome. And in fact, the other subgroups shown here, PO and PH, for example, had relatively low levels of metabolic syndrome, in fact, comparable to that in the controls. And in fact, when we look at insulin resistance as well, insulin resistance appeared to be confined to the subgroup with all three criteria. For those who only had oligoamenorrhea combined with PCO morphology or hyperandrogenic features combined with PCO morphology, that in fact their insulin sensitivity was similar to control women. So really the take-home message from this slide, and I've taken a lot of time deliberately to go over this slide because it's a very important point, the evidence suggests that it's the women who have the oligoamenorrhea and hyperandrogenic features, in other words, the reproductive and hyperandrogenic features combined, these are the ones who tend to be insulin resistant and who tend to manifest with metabolic dysfunction. So although it's true to say that PCOS as a whole associated with metabolic dysfunction, as I said, it tends to be those with the both reproductive and hyperandrogenic features combined who are most at risk. And this, I think, is helpful when we're focusing on our patient groups and we're thinking about which patients we need to be most vigilant in terms of screening for, monitoring and managing dysmetabolic features. Now, as we showed earlier, the Rotterdam criteria, the 2 out of 3 criteria, reproductive and hyperandrogenic features, there's no mention in the Rotterdam criteria about metabolic dysfunction. This does not feature with regards to its diagnosis. But this in no way diminishes the importance of metabolic dysfunction in PCOS. It clearly is a metabolic condition. In fact, there's even been a suggestion that we should rename it as syndrome XX, okay? So, in other words, female metabolic syndrome. And all of these features shown here, as of course obesity, but type 2 diabetes in 10%, impaired glucose tolerance in 30 to 40%, hypertension, obstructive sleep apnea, a 5 to 10-fold increased risk, insulin resistance, as we've heard, an inherently insulin resistant condition, and dyslipidemia. All of these dysmetabolic features occur in women with PCOS to a higher level than what you would expect in BMI and age related control women. So it's just important when we're managing these patients just to be mindful of that. You know, it's not just a case of managing their reproductive and androgenic features. We need to be screening for all of these metabolic features and being really, I think, proactive in our approach to managing metabolic dysfunction. So coming towards the end of my talk now, let's move on then to think about certain management strategies regarding weight loss. What is the evidence to show that weight loss is useful in obese women with PCOS? Well, there was a very interesting study shown here, the reference at the bottom there, looking at just 5% weight loss in obese women with PCOS, and showing that there was a 25% improvement in live birth rate, a 48% improvement in spontaneous ovulation, a 32% improvement in the pregnancy rate, and a 56% improvement in regular menstrual cycles. So very good evidence from this study and other similar studies which show that relatively modest weight loss, even just 5%, can have substantial clinical benefits in terms of reproductive functioning in obese women with PCOS. Now, I don't have a slide on this, but there's also been studies looking at the effects of weight loss, relatively modest weight loss on, for example, hyperandrogenic features, like, for example, free androgen index, and showing some significant improvements in free androgen index and elevations in sex hormone binding globulin, which typically occurs in women who lose weight. Let's not forget SHBG is a very good, incidentally, a very good marker of insulin resistance. And in women with suppressed SHBG, this tends to indicate that they have insulin resistance. And of course, a low SHBG translates into an elevated free androgen index and worsens androgenicity. So reducing weight improves SHBG and thereby improves FAI. And there's also, as you'd expect, good evidence to show that losing weight in obese women with PCOS also improves the the metabolic features, including, importantly, insulin sensitivity. Now, you've seen this slide already, and this is, of course, the overview of the pathophysiology of PCOS. But really, the point of showing this again is that when we're thinking about the best treatment option, really, for these women, it's often focusing on weight loss. Why should that be? Well, it comes back to the central importance of insulin resistance as a mediating effect of obesity on the features of PCOS. So anything which can improve weight is likely to improve all of the features of PCOS. And we know, for example, that there's been studies on bariatric surgery, systematic analysis and meta-analyses and so on, which were published quite recently, actually, on bariatric surgery in obese women with PCOS, showing improvements in the testosterone levels, in androgenic features, in reproductive function and metabolic features as well. There's also studies looking at orlistat, which is an obesity therapy, which has shown improved body weight and also improvements in androgenic and reproductive features. And even studies looking at liraglutide, a GLP-1 based therapy, which has shown improved weight loss and also insulin sensitivity in obese women with PCOS. So there's some very interesting data in the literature looking at improvements in body weight, not just from bariatric surgery, but looking, pharmacotherapies as well, which show improvements in the features of this condition. And then, of course, there's metformin, which, of course, is known to improve the reproductive features, particularly in women with PCOS. But remember that metformin is an insulin-sparing drug. We don't fully understand its action, but we believe it acts primarily within the liver to reduce the need for insulin. And so, of course, by using metformin, we would expect insulin levels to drop somewhat. And this, of course, may go some way, at least, to explain some of the beneficial effects of metformin in women with PCOS as well. So with that, I'm going to now hand over to my esteemed colleague, Professor Thaler, who I introduced earlier, and I'm absolutely delighted to be able to share this webinar and the following discussion with Professor Thaler. So now I'm going to end my slideshow here, and hopefully Professor Thaler can share his slides and proceed with the next talk. So let me just stop share. Okay, so hopefully Professor Thaler, you'll be able to share your slides now. Hi, Professor Thaler, I think you're muted. Could you unmute yourself?
Here you go.
Oh, yeah, we can hear you now. Yeah, that's working. Yeah, thank you.
All right, thanks. Thanks, Tom. Hello to the group. With this wonderful spring day from Munich, 3 in the afternoon, it's great to be part of this. And Tom, after you said all, I don't think I can add too much more. Maybe a little bit as far as reproduction, maybe a little bit as far as getting pregnant. And of course, that's a key feature as far as anovulatory problems is concerned. And I'm a reproductive endocrinologist, and in fact, a couple of our patients present with exactly this problem. And there are several recommendations how you proceed as far as stepwise. I think Tom spent good time and very good, clear concepts on the definition and the diagnosis. I won't go into this. And maybe we go into the therapeutic options right away. And the first one, I think it's a key message. It's really the way the woman, the anovulatory woman, the hyperandrogenic woman achieves her weight reduction. I think it got very clear after Professor Barber's comments that this is really a key one, and it's therapeutic. In fact, Consigliani and others, I think you showed the study, showed that a relatively modest reduction of weight by some 5 to 10% BMI reduction really improves several features, including ovulation, pregnancy, implantation, the whole spectrum up to live birth. By the way, it also reduces the androgens. It's the way to go really. Of course, it's not all that easy, but these days several pharmacologic interventions are very effective, as it turns out. For a long time, we had diet and sports and these things, and nowadays I think it's a medical issue that we can really attack. The next thing here is metformin, and that's an interesting one because for some time it seemed to really target one of the key problems of PCOS. Well, I skip over the definition thing. And I concentrate on the recommendations. The most current one is the evidence summaries on recommendations from international evidence-based guidelines. Another one which is similar to this, and it's kind of predecessing this publication in Human Reproduction, is the ESHRE guidelines, which were written and published from Thessaloniki. It's a little bit like the Thessaloniki guidelines. It's kind of corresponding to the Rotterdam criteria as far as the definition. The people who got together is basically the Thessaloniki guidelines. Like I say, the lifestyle intervention, and that's a very clear one, and there is good evidence for this, gives you a good advantage in improving ovulation, improving pregnancy rates, improving live birth rate. The next one is, like I say, metformin and clomiphen. Now, the metformin, of course, targets the insulin. The mechanism is not all that clear, but there has been quite a lot of evidence that using metformin really, by reducing the insulin and reducing the effects of the insulin on the ovary, on the follicular genesis, increases the chances of an ovulation. The other drug that has been used basically as a parallel option, the clomiphen, is a sort of a classic drug that has been used in central anovulation by the selective estrogen receptor modulation. It's like the tamoxifen, basically increasing the FSH in the pituitary, and that's the other option. Now, the metformin really seemed to be the golden bullet in the late 90s. And here is the classic study by Nestler and others, small group and a very high impact, New England Journal of Medicine, where they basically used a relatively small group of PCOS women, and half of them received the metformin. And you see that out of these, about 30% went to get ovulatory cycles. So that seemed relatively encouraging. And if you add Clomiphen to the unovulatory group, so the women who still did not ovulate, you end up with a very large proportion of these women who actually ovulated, close to 90%. So adding metformin as a first line and Clomiphen as a second line, you end up in 90% ovulation. Now, if you do the other way around, the women who ended up on the placebo group in the first line, and if they got, of course, none of them ovulated, if they then were added the Clomiphen alone, you had an ovulation rate of only 12%. So this really seemed for a long time, and I remember this, I was part of it, that metformin is really the way to go. And the other advantage of this was really that you did not have to monitor the cycle, because metformin, of course, doesn't have any twin or triplet risk. So for a long time, we were going with metformin, and we thought this is basically the answer. And of those who did not ovulate with metformin, we added Clomiphen, and the idea was that's the way to go. Now, as you can see, the study here was not all that great. It was prospective, it was randomized, but it's a really small group. That's 90s for a New England Journal. And there was another one, which was more or less 10 years later. And this was really a very large, multicentric, multi-institutional study, prospectively designed, where they studied Legros and others. They studied metformin versus Clomiphen versus a combination. And the result was really quite amazing. Namely, only about 20% had a baby 2 or 3 years later with the metformin, whereas the Clomiphen alone was much more efficient, and adding the metformin to the Clomiphen did not really make too much difference. So that really changed the entire spectrum 10 years later. And at that point, the recommendation, that was the Thessaloniki recommendation, clearly stated, go for Clomiphen as the first-line pharmacological intervention if the weight reduction doesn't work. Now, since then, things changed again a little bit from 2 reasons. Letrozole, which really is a totally different concept, as it's an aromatase inhibitor, and it also increases ovulation. You can use it. It's not only as an oncologic treatment. I think many of you will know it for breast cancer, estrogen receptor positive breast cancer, as it reduces the estrogen. It also increases follicular genesis. And in fact, it turns out to be even more effective as far as pregnancy rates as compared to the Clomiphen. One of the reasons being that it does not have the anti-endometrial activity of the Clomiphen. That's one of the big disadvantages of the Clomiphen. Of course, all of you have used this, see that the endometrial reflex really decreases. The letrozole doesn't do this. And also the letrozole is much more efficient in actually inducing a monofollicular cycle. So that's really nowadays the better thing to go. It's not Clomiphen, it's really letrozole. And here is the Cochrane review, which clearly states, and you can read this, that the aromatase inhibitor letrozole is actually better in fertility with PCOS. Here is the evidence, and it says letrozole should be considered first-line pharmacological treatment for ovulation induction rather than the Clomiphen. When letrozole is not available or use permitted or cost is prohibitive, you can go for other agents. Now, that's actually the case in Germany. I don't know about your systems. Here, letrozole is off-label for us. If you use it for ovulation induction in PCOS women, we actually have a off-label problem. but actually the same thing is true in our country for the metformin. So the only thing which is officially in label for us still is Clomiphen, but we don't care too much about this because the evidence is quite clear. And now, as far as the multiple pregnancy, the multiple pregnancy risk, the letrozole is actually better. It's more efficient. So that's really basically the one to go for. It's not metformin, it's not clomiphen, it's really letrozole as the first line pharmacological interventions if you can use it. And of course, it's relatively inexpensive. That's the difference as compared to the gonadotrophins. Of course, these days, gonadotrophins typically are recombinant, and you can use a low dose recombinant FSH preparation. That is very efficient, and you can also use it in letrozole or clomiphen resistant patients. However, it's of course expensive. You need to monitor the cycles. You have the problem of the polyovulation. So the recommendations here is you may use gonadotrophins. You may use it as a primary option. That's a possibility, although it's relatively expensive. You should use it in resistant patients who do not respond to the clomiphen and or the letrozole. And like it says here, number 3, it's effective, of course, as a first line. And if the other 2 options doesn't work, then it's basically a step 4 as far as the Thessaloniki criteria is concerned. Now, here is a completely different way of approaching this, and this is more going to I'd say, the morphology of the ovary. It's kind of interesting that the ovary, of course, has a thickened tunic, and this, of course, was already evident for Stein-Leventhal, the 2 guys who first described the syndrome, I think in Chicago, with this very small group, a couple of patients, the Stein-Leventhal syndrome, and they say the thickened tunic is apparently prohibiting the ovulation. I mean, they really thought very much sort of in the concept of the morphology of the ovary. And this goes a little bit in this direction as if you do a laparoscopic surgery. In other words, if you use a laser to make holes in this tunic, maybe even to destruct the surface of the ovary. Others maybe use even mechanical stimulation. This does actually result in ovulations for about 6 to 12 months, and it's as effective as the pharmacological induction. So that's quite interesting. That's another way, and the Thessaloniki criteria sort of recommend this as an alternative. And the alternative is particularly interesting, of course, if you are in a country where monitoring is not so easy, if you're in a country where maybe cost prohibitory, and if you have another reason for doing the laparoscopy. For instance, you look at the tubes, or you do a laparoscopy from other reasons. And if there is an additional problem as far as PCOS, you might use being there basically on laparoscopy and in doing laparoscopy surgery. Of course, it's not resulting in any twin or triplet risks. So it does have a couple of advantages. It's an alternative. And as far as the effectiveness, it's basically as effective as a low-dose FSH. So it's an interesting one. It probably does not last very long. Probably after 1.5, 2 years, the women start getting anovulatory again. And of course, it might have disadvantages. For instance, adhesions. For instance, maybe even reduction of the ovarian reserve. That's not really quite clear. but I think it's an interesting aspect and it should be mentioned. Now, finally, of course, some of these women still at that point, this is basically the end of Thessaloniki recommendations, they still are not pregnant. And then you might go into assisted reproductive technologies like IVF-ICSI. There, it's a little tricky because the PCOS patients are, in fact, at high risk of some of the complications, particularly ovarian hyperstimulation syndromes. As you probably know, this is sort of the tricky group of patients, as if you give a little bit too much of the stimulation dosage, you end up with 30, 40 follicles. And with a patient who has a problem, if you have a little too little, you have a non-response. That's probably due to the high AMH, which is anti-FSH. And so that can actually end up to be a big problem. It's tricky to stimulate them. It says not to use LH and not to use HCG activity for the stimulation. So you just use pure recombinant FSH at the sort of a very balanced dosage. And you might want to, that's actually what we usually do, you might want to use a GnRH trigger in a freeze-all to really avoid hyperstimulation syndromes. That's a good one. And another one, which is good to use, to actually use adjuvant metformin. Maybe you start at the time of stimulation. Probably it makes even sense to start this 1 or 2 cycles in advance as a sort of a preparatory thing. There's pretty good evidence if you use 1,000 to 2,500 milligram of metformin per day, that you increase the pregnancy rates and you reduce the incidence of ovarian hyperstimulation syndrome. So IVF is a good idea. You usually get a lot of eggs, but you need to be careful not to run into problems. That's a Cochrane review that I'm citing here. So that's pretty good evidence. If you do IVF-ICSI in PCOS patients, you might want to think about using the metformin as an adjuvant. Finally, I think, Tom, you went a little bit into this. The pregnancy also may be a problem. There is a consensus statement, that's the Amsterdam group. So we went through Rotterdam, Thessaloniki, finally we ended Amsterdam, where the ASRM and the ESHRE published basically their data on pregnancies in PCOS patients. And of course, one of the big problems is the diabetes, the pregnancy-induced diabetes, and the big for gestational date babies. So that's, again, it's not the only problem to get these women pregnant, but also to keep them pregnant and have healthy babies. That's as far as I'm concerned, and as far as the pregnancy and the reproductive part of PCOS is concerned. And I'm back now to Tom. If there are any questions or discussions, I stopped sharing my screen, right?
Yeah, that's fantastic. Thank you so much, Professor Thaler. If you can stop sharing your screen now. So before we go on to the Q&A session, I just need to say that the webinar is sponsored by MDforLives.com, which is a premier healthcare market research firm, and medical doctors can register for free and become a part of this global community, take up surveys, participate in quizzes, and earn honoraria. So why not sign up today? So we have a Q&A session now. As I mentioned, we will finish at by 3 o'clock, but we should have around a quarter of an hour for Q&A. And as mentioned earlier, please do post any questions on the Q&A function. And I see that we actually already have some questions come up now. So maybe I can kick off then. So Professor Thaler, I think this one's for you for the first one. And so the question is, what GnRH antagonists are there or will there be in the market, and how effective are they? What are the contraindications and how safe will they be? And how effective are omega-3 supplements in PCOS as well? So that's a bit of a compound. I think there's 3 questions in one there, but I don't know if you want to tackle that one at all.
Well, see, for a long time, we had in the typical controlled ovarian stimulation, we had only the GnRH superagonists, which have a flare to start with, and which we usually start in the late luteal phase of the pre-treatment cycle. One of them nose spray, others subcutaneous injection. And the disadvantage of these is that you have to ovulate by using HCG. And the HCG, of course, stimulates the corpora lutea. And if you have a large number of these, which is quite a common feature in the PCOS patient, because many of these follicles that you stimulate now start getting transformed. They are corpora lutea. And if all of them keep being stimulated by the HCG, which has a relatively long half-life of some 1.5 days, and if you inject 10,000 units, that can carry on for a week or longer, that really basically increases the hyperstimulation problems. Now, this was solved, pretty much solved. This can really reduce hyperstimulation problems to close to zero if you have an antagonist, and there are several antagonists in the market. You remember that GnRH is a decapeptide, and if 2 or 3 amino acids are changed at the region where the RNase peptidases come in, and so these GnRH is acting for typically it has a half-life of 3 minutes, but if these amino acids are changed, it can be hours, days, and even weeks. And so if you have the antagonist, it basically stops the pituitary right away. Okay. Now you typically start these only at day 5 of the stimulation, when the follicles start getting larger and the LH might come up. And the advantage of this, if you now come in with the superagonist, which we used before in the long protocol, that basically goes on top of the antagonist, and that causes a flare. So you get a lot of FSH plus LH come out. And the LH is high enough to really ovulate. And the LH has a half-life of only a few hours. So after ovulation, after inducing the meiotic division and the follicle and releasing the egg into the follicle fluid, it basically does not act anymore, and it does not stimulate the corpora lutea. So in other words, if you do this, you don't have an overstimulation syndrome. Most of these patients, after 1 or 2 days, even if they have 30, 40 follicles, they feel okay again. And of course, you don't want them to get pregnant in this cycle. So you do freeze all. That's what the studies say. And doing this, we basically can solve the threat of hyperstimulation by doing a sort of a two-sided thing. We freeze them away, and maybe 1 or 2 months later, they get pregnant.
That's fantastic. Thank you so much for that. Now, we've got a few questions coming through, so we'll do our best to answer them. So there's a question here to clarify the interrelationship between PCOS and the adrenal gland dysfunction. So as I kind of alluded to in my talk, there's really 2 main kind of aspects to this, really. There's the direct effect of hyperinsulinemia on the adrenal gland, stimulating adrenal androgen production. But there's also a more proximal effect acting via the hypothalamo-pituitary unit. And I mentioned earlier that 5-alpha reductase activity is typically enhanced in PCOS, and this one of its effects is to convert cortisol to its breakdown products, and that releases the negative feedback on the hypothalamic pituitary unit, thereby enhancing ACTH release and thereby further driving adrenal androgen production. So there's really two mechanisms here, both, as I said, one implicating insulin, the other 5-alpha reductase, but there is definitely often adrenal androgen production as well in PCOS. Another question is a male equivalent of PCOS, a very interesting question, a bit of a controversial area that we don't fully understand is the answer to that. PCOS is a genetic condition, and some of the genetics acts through effects on obesity. For example, FTO, I was actually published this in my PhD. We showed that there is an association between one of the variants in FTO, one of the genomic genome kind of variants which can impact on BMI, and I showed that there is an effect on PCOS. So in other words, the genetics of PCOS is at least in part mediated via effects on obesity, and so this could act in male relatives as well, although, as I said, it's a bit controversial that, and we don't fully understand that, but it's an area of ongoing interest. And then the question here, well, actually for you, Professor Thaler, question here, what about myo-inositol? Does that have a role, do you think, in PCOS? Again, a bit of a controversial area, but
there is some hints going to this, and of course it's a relatively easy thing to add as a first line. There is no good evidence, there are no really good studies that they increase monoovulatory cycles or alike, but I know many doctors who recommend maybe in addition to trying to reduce BMI, such an approach. It has not gotten in any of the evidence-based recommendations, but I don't see any problems with it. So it may be a first line.
Okay. So there's a question here, why not see weight gain and obesity as a symptom of PCOS instead of mostly considered as a cause? Now, it's a very good question, and I think it's a very important point, actually, because it's easily misunderstood. Emphatically, PCOS does not typically result in weight gain and obesity. Of course, there could be indirect mechanisms. So, for example, effects on mood and depression and reduced activity levels and impacting on diet, causing weight gain and so on. But usually the main reason for the association is that women who gain weight typically develop PCOS for the reasons I explained. Okay, so mainly effects on insulin resistance and insulin levels. Okay, so it's an important point to make there, is that PCOS doesn't normally cause weight gain. It's usually the other way around. Okay, so I hope I've answered that question there. And then another question mentioning about phenytoin. The question here mentioning phenytoin as a cause of PCOS, and that the questioner says they believe that valproate is a primary cause as well, even beyond weight gain. Now, I think an important point to make here is that I didn't actually say that phenytoin causes PCOS. Okay, the purpose for mentioning phenytoin and cyclosporine, for example, is that a side effect of these drugs can be hirsutism, okay, which can manifest in some of the ways like PCOS. Emphatically, it doesn't normally cause PCOS as such. Okay, so I think it's an important point to make there. With regards to valproate, I mean, again, there may be effects via weight gain. I'm not aware of any direct effects of valproate as a cause, as a contributor to PCOS. I don't know whether, Professor Thaler, if you have anything to add there in regards to valproate, or
I think it does actually interfere with the CYP metabolism. Okay. And there is actually, I think you can even measure some of the androgens increased in these patients. So okay. It does actually tie into the androgen production.
Okay, so there may be effects there on androgens, but I think, ultimately PCOS is a genetic condition. and you're born with a genetic predisposition, and then the current thinking is that if you then gain weight, it can then become clinically manifest. But of course, there are factors which can influence its expression, and I guess valproate would be one of those. So here's a question for you, Professor Thaler. Sorry,
I think, Tom, maybe to really amplify a little bit on that one, it's very important, and I think you stressed that point, that you need to really be careful not to go for the most relatively typical thing. If you have anovulation, you have the typical ovary, you say this is PCOS full stop. There may be adrenogenital syndrome, a heterozygote, like you say, look at the 17-hydroxy progesterone, and there may be a tumor. And these are really very important, relatively rare situations. I mean, we are talking about 2-3% of those patients, but don't miss them. That's really important. For the other ones, all what we say is important, and it usually works. But I think that was a very important point that you made.
I completely agree with you. And I think in particular, as I said earlier, one of the problems in medicine is that once a diagnosis is made, especially if it's coming from a specialist, then it tends to stick and it gets replicated, and GPs believe it. And I think it's very important, as you say, to make every effort, at the diagnostic stage, before you actually say this is PCOS, to exclude everything else that could be, manifesting in this way. I absolutely agree. Now, there's a question here, Professor Thaler, for you. So, as most PCOS patients have baseline low progesterone, are there any studies to supplement progesterone to keep pregnancy in women with PCOS, to maintain?
I think that's a very important point, because the problem is really anovulation, and the sort of a predecessor to anovulation is the luteal phase deficiency or insufficiency. So of course the baseline progesterone is not important, but the luteal phase progesterone. You want this after the ovulation, you want this to be above 10 nanogram per ml. If you have 7 or 8, some doctors say, okay, we need to supplement the progesterone. But the low progesterone is only a symptom of immature follicles. Okay, so don't substitute progesterone. Try to have a mature follicle to ovulate, and if the follicle is mature, you will have a good progesterone. So the answer is, don't substitute the progesterone, but look to have a mature follicle. That will take care of this.
Fantastic. And the question here about PCOS and gestational diabetes. Yes, of course, there is a link with GDM as well. PCOS is an independent risk factor for GDM. So as with the type 2 diabetes, pre-diabetes and so on, hypertension and so on, and indeed GDM. So we should be, in terms of screening pregnant women for GDM, I think we should be particularly vigilant in women with PCOS, because their risk is higher. Another question about which medicines can help lose weight in PCOS. Well, we're not exactly, we're slightly impoverished in terms of our treatment options for weight loss, particularly in the UK. We don't have many therapies, and unfortunately, in terms of licensing, that they're not usually often licensed in PCOS either. This is a problem, I think. I think it's, hopefully we'll have more therapies in the future. Clearly, there's a lot of interest in the GLP-1 class, semaglutide and so on, in obesity in general, although not so much studies specifically looking at PCOS. I think one of the problems in PCOS, of course, is the reproductive aspect. If you have a drug which really helps with weight loss, you've then got to consider what happens if the woman then gets pregnant. Okay, and unless the drug's being studied in pregnancy, there's always potential, concerns about teratogenic effects and so on. And unfortunately, the weight loss therapies that we have typically are not usually licensed in pregnancy for that reason, because simply they haven't been studied in that context. So I think it's just a kind of general point really to make about weight loss therapies. Just be cautious about that. But I mentioned earlier that there's a meta-analysis on bariatric surgery in obese women with PCOS, which shows it can be a very effective treatment option in that context. So a question here. I'm aware of the time. Maybe we'll use this as the last question, actually, and then we'll wrap up. But the question is there a role for low-dose glucocorticoids, either for lowering testosterone and or helping in ovulation induction? So I don't know, Professor Thaler, do you want to tackle that one?
It's effective in reducing the androgens, of course, but it is not effective in increasing the ovulation. And it's not so easy if the woman then gets pregnant, because you don't want the glucocorticoids in place at that point, because there are a lot of problems as far as the pregnancy is concerned. So we don't use that. And of course, as far as the insulin and the glucose, it's contra-effective. You don't want the glucocorticoids in a woman with insulin resistance, as that's getting worse. So I would not recommend this.
Yeah, I absolutely agree. Actually, I think I completely agree. Yes, the metabolic concerns about using steroids, of course, and glucocorticoids it would be, I think, a concern there. So I think we'll wrap up there, because it is we are on time. I just want to finish by saying you can reach me on email. I'm at t.barber.warwick.ac.uk. I'd like to thank the organisers at MDforLives for setting up and organising this webinar. I think it's been a fantastic webinar, actually. I think it's been a great discussion and some really insightful questions. I'd like to especially thank my co-presenter, Professor Thaler, for his excellent presentation and excellent discussion. And finally, I'd like to thank all of you for joining the webinar and making it into such a excellent and interactive session. Thank you.
Thank you so much. It was fun to be part of this. Have a good day.